Assalamu alaikum wa rahmatullahi wa barakatuh. Good day to everyone. Great pleasure for me to be with you today. My name is Osama Haji, consultant rheumatology and associate professor at Ain Shams University. Today, our paradigm is shifting to an early diagnosis of rheumatic and musculoskeletal disease. What is the value of this? The value that we diagnose the patient as early as we can to give the patient the best chance of treatment, and our mission is remission or low disease activity. Our journey today has a multiple station. The first and the most important one is rheumatoid arthritis. As you know, that rheumatoid arthritis is affecting 1% of the population. The disease has collateral damage in addition to joint destruction. The second and important disease, which is gout arthritis. Gout affecting 4% of the population in an early way and is causing, again, joint, articular, extra-articular, even it is a systemic disease with a joint affection. And the third disease, which is systemic lupus erythematosus, low, it is low from 0.3%, but it is a serious disease that can affect any organ system in the body. Let us start our journey with the first station, rheumatoid arthritis. As you can see in this slide, that rheumatic and musculoskeletal disorder, how early is early? We don't like to be years. We don't like to be months. Our aim is to diagnose within few days, few weeks, as early as we can. And you can see in this image in a very clear way that clock is not a compass. Our aim is time and to be in the right direction. Our mission is to diagnose the patient as early as we can. Please, we should make this image or photo as a part of the history. We don't like to see this hand anymore in the daily clinical practice with multiple joint deformities, ulnar deviation, and imagine what is the quality of life this patient. To diagnose early, we can see this simple case that the patient, old age, polyarthritis, he has a comorbidity, shoulder impingement syndrome, hypertension, dyslipidemia, and ischemic heart disease. The patient has arthritis with tenderness and swelling. But if we apply the criteria to this patient, we cannot, because rheumatoid factor is negative. And please, I'm reminding myself, reminding all of you that RF is not rheumatoid arthritis. And this patient has negative RF. But ACPA, which is CCB, cyclic saturated antibody, is highly positive 500. So you may see a patient with negative RF, with negative CCB, or positive any one of them. So RF is part of diagnosis. But again, the acute phase reactant for this patient is high. If we're applying the old criteria 1988, it's difficult to be applied because it is diagnostic classification criteria. What does it mean? For diagnosis of typical, classic, advanced case. We don't like to see radiological change by plain X-ray. We don't like to see subcutaneous nodules, and rheumatoid factor is not a part of diagnosis or simple part of diagnosis. So it is not yes or no. It is a part of quantum. It is a timeline. We can diagnose patient with inflammatory arthritis, and later on the patient is developing rheumatoid arthritis. And you can see this case, Mr. Muhammad is 19, but he has a positive family history of the mother with seropositive rheumatoid arthritis, severe and using biological agent. He's just developing polyarthralgia. And no specific diagnostic tools, and RF is weak positive, and ACPA, weak positive. But with time, with developing manifestation, the patient developing polyarthritis, increasing titer of rheumatoid factor and ACPA. As a time, it is sure diagnosis, but we can diagnose within few days, few weeks, again, not months, not years. So it is not diagnosis, it is a probability of being rheumatoid arthritis. What does it mean? If we have these two patients with low positive RF and multiple joint affection, or just low high positive with only two, which patient will be liable to developing rheumatoid arthritis? This is the beauty of the effort done by American College of Rheumatology and European Alliance of Rheumatology Association. This criteria is published in 2010. As you can see, there is 3 domains: joint involvement, serology, acute phase reactant, but the patient must have more than 6 weeks of manifestation, duration of the disease. So we can diagnose rheumatoid arthritis if the patient is positive CCB or rheumatoid factor, acute phase reactant is high, more than 6 weeks, and only 2 joint affection. And again, our aim is not diagnostic, our aim is to give the patient the best chance of remission or at least low disease activity. Please apply this criteria in daily clinical practice for the sake of early diagnosis of our patient. And this is the first station.